Hi, everyone. Thank you for joining. We're going to give it another minute or so for folks to trickle in, and then we'll get started. Hi, everyone, and welcome. Thank you for joining us today. My name is Fedger Saeed Ibrahim. Fedger rhymes with ledger, if that's helpful. I use she, her pronouns, and I serve as the Senior Policy Manager at the National Asian Pacific American Women's Forum, or NAPAWF. I'm going to pull up the slides here. Perfect. Thank you so much. So at NAPAWF, and we can go to the next slide and the next slide after that. We're proud to be the only national organization dedicated to public policy advocacy through organizing for Asian American and Pacific Islander women and girls in the United States. Our work is guided by reproductive justice, which we can go to the next slide for, which goes beyond traditional reproductive rights and healthcare to address the structural, political, and social factors that shape our ability to make decisions about our lives, our futures, our bodies, and our families. Reproductive justice was founded by Black women in the 90s on the belief that all individuals and communities should have the resources and the power that they need to make their own decisions about their bodies, their gender, their sexuality, families, and lives. It's more than just access to healthcare. It's about dignity, autonomy, and equity. Next slide, please. So to put it simply, and this is just to ground us for the conversation today, reproductive health refers to clinical care and services like birth control, prenatal care, and abortion. Reproductive rights focuses on legal protections, so the right to contraception, the right to abortion, and the legal frameworks that protect those rights. And then reproductive justice is broader. It recognizes that legal rights and healthcare access alone aren't enough if systemic barriers like racism, economic injustice, immigration status, or cultural stigma prevent folks from actually exercising those rights. That's why today's conversation is so important. We're here to present the findings of the NAPAWF report on Asian American, Native Hawaiian, and Pacific Islander sexual and reproductive health in Georgia, which examines the barriers that our communities, I'm just going to say AANHPI communities, face in Georgia when they seek sexual and reproductive health care. This report helps us understand the unique challenges our communities face and identify solutions that center equity, cultural sensitivity and humility, and meaningful access. We know that AA and HPI communities are often left out of reproductive health conversations. So when people think about barriers to care, they may not immediately think of the challenges facing our communities, but here's what we know. Language barriers, cultural stigma, and immigration policies, and on top of all of that, systemic racism, all shape the reproductive healthcare experiences of our communities. These barriers don't just exist in policy, they show up in exam rooms, in pharmacies, in conversations with family members, and in the deeply personal choices people make about their bodies and their futures. And while these challenges are daunting, especially now, knowledge is power. That's why research, like the report we're discussing today, is critical. It provides concrete evidence on the gaps and barriers our communities are facing and helps us push for policy changes that ensure access to care and to make sure that that access is not a privilege, but a right. Before we begin, I should say, I want to encourage everyone to submit your questions in the Q&A box. For those of us joining on YouTube, you can add your questions in the comments as well. We'll be saving time at the end to address your thoughts and your questions. We want this to be a conversation, so hopefully you can engage. And I'm thrilled that we get to dig into this research today with an incredible expert who has dedicated her career to understanding and addressing reproductive health disparities. I am honored to introduce Dr. Subhashri Narasimhan, our special guest today. Dr. Narasimhan is a public health social scientist with extensive expertise in sexual and reproductive health, maternal and child health, and intimate partner violence. Her work spans sub-Saharan Africa, Asia, and the southeastern United States, bringing a global and intersectional perspective to the study of reproductive health disparities. She completed her PhD in community health sciences at UCLA's Fielding School of Public Health, and at Emory University, Dr. Narasimhan joined the Center for Reproductive Health Research in the Southeast, that's the RISE Institute, as a postdoctoral fellow, where she led innovative research exploring the impact of policy restrictions on abortion access, contraceptive use, and the overall health and well-being of people capable of pregnancy. Her work employs mixed methods and multi-level approaches to uncover the real-life consequences of restrictive reproductive health policies, making her insights not only vital for research, but for advocacy and policy change as well. Dr. Narasimhan, welcome. We're so excited to have you here today, and I'll pass it along to you.
Thank you so much, Fedger. I really, that was such a kind introduction, and I'm very excited to be here. Next slide. Um, as Fedger pointed out, I am an assistant professor at the Emory Rollins School of Public Health, but I'm also an affiliated faculty with the Center for Reproductive Health Research in the Southeast. And I come here as a representative of that group, but also as a partner in the work that NAPOF facilitated, created, envisioned, looking at health disparities and sexual and reproductive health access for AANHPI folks. Next slide. So I'm going to give you a little taste of what RISE is, some of our goals, our ethos, but then also just a little bit of a norming landscape for you all to understand a little bit about, sexual and reproductive health policy in Georgia specifically. So first, who are RISE? What is RISE? So RISE is a collaborative research center at the Emory Rollins School of Public Health, but we're also a network of stakeholders who are accountable to focusing on reproductive health, rights, and justice specific to the Southeast. All of our work focuses on the idea that it should be justice-driven, community-centered, and inform the change in social systems and policies. Next slide. So as a center, what do we actually do? We do a few things. This includes research for action. We are a public health research center, but we also do partnership building, where we try to connect community groups with researchers who might be supportive of research ideas that they have. We're very, very serious about training the next generation of scholars, particularly Southern scholars and scholars of color, in order for them to tackle the real persistent inequities that exist within this part of the United States. And then finally, we prioritize communication to community over communication to the ivory tower. So our focus is that we always involve community in every aspect of our dissemination and include community-facing materials to make sure that all the research that we do, all the findings that we have are much more accessible to people who may not be at institutions like Emory University. Next slide. So all of our work is really informed by this justice vision. This idea that power sharing, especially political power sharing, is something that's long been overdue in terms of research work. And we value both cultural and spiritual knowledge, experiential knowledge, but also academic mainstream knowledge. We look at all of those as equal, and thus the idea that somehow just quantitative work or empirical work is more important would not fit or would not support the ethos of our center. Next slide. So this research justice framework, what does it really mean? What it means is that we follow a couple of different rules. First, the right to know. We believe that communities should have unfettered access to the production, documentation, and possession and use of their own data. So they own data, right? And data can also be power. We believe in the right to be heard. so that community knowledge and methods to attain that knowledge should be recognized as legitimate. So again, that we're not just privileging things like statistical methods, that there's value in other modalities, including focus groups, interviews, listening sessions, and simply just being together in community. There's value in that. And then finally, the right to self-determination, that the research infrastructure should be built to ensure accountability to community needs and demands and not the other way around. That community should not be at the beck and call of large organizations. So, why does that ethos matter? I think it matters a lot because in some ways, this strategic framework that really focuses to achieve self-determination for the communities around us, particularly those who might come from marginalized backgrounds, centers community voices. And I think that may also be the reason that we have this great partnership with NAPOF and how this work came together. So let me give you a little bit of background of how this partnership came to be. In July 2021, RISE invited people from the Georgia RHRJ, or Reproductive Health and Reproductive Justice ecosystem, to submit research concepts for consideration. And the hope was that they would be able to fund research in a 2-year time frame that answered a question that communities desired. The call was wide. There were no restrictions on what types of groups could apply or how small or large the group needed to be. But the goal was to privilege very specific priorities, and those priorities included looking at person-centered sexual and reproductive health care with a focus on abortion, contraceptive care, or other clinical policies or clinical hurdles to healthcare access. Giving privilege to teams in the Southeast, and then finally making sure that the leadership or co-leadership was led by people of color who might identify as Black, Indigenous, or other people of color. And so with our luck, NAPOV applied and their work was seen as, extremely exemplary, and then this partnership grew. Next slide. So I've given you a little taste of like the background of RISE, but also how this partnership came to be. But now I'm just going to give us all a little bit of a background of what it looks like to try to access reproductive health care here in Georgia, but also maybe a little bit about the laws that people might encounter. So I'm going to focus on a couple of different areas. One is comprehensive sexual education. The other is pregnancy disparities and pregnancy healthcare deserts, contraceptive deserts, and then finally abortion care. And I think that everyone in the audience probably knows a smattering or two of each one of these things. And I'm hoping I can bring a lot of different topics together so you can kind of see what the Georgia landscape might look like for somebody who's trying to get sexual and reproductive health care. Put yourself in the mind of an individual who might just be trying to do, an everyday task like getting their own, healthcare appointment. So in terms of Georgia, until it might surprise people to know that until very recently, actually, Georgia was considered a bastion of sexual and reproductive health care. Not that there weren't hurdles, but in comparison to many of the other states around it, people would come from other states which had much more restrictive laws to Georgia to receive things like abortion care. And that trend is still in existence despite us having much more highly restrictive laws. So what's really like what that kind of highlights to me and highlighted to me when I moved to Georgia actually was that like Georgia was like this very important place in the sexual and reproductive health landscape. And it's also a state where the AANHPI population is growing rapidly. And so these two things together, really, really need to be examined. So what does comprehensive sexual and reproductive health education look like? for Georgians? Well, in Georgia schools, they're required to provide sex education and AIDS prevention education. When a recent study by SIECUS saw that, basically 33% of all critical topics suggested by SIECUS were covered by Georgia schools. But there's no standard on medical accuracy. And many people get abstinence-focused or abstinence-based sexual education. So there's a lot of unevenness to the landscape of sex education. And curriculums, again, because they can provide abstinence-based sexual education, not comprehensive sexual education. Comprehensive sexual education isn't mandatory. And curriculums do have to emphasize abstinence. That's written in the law in Georgia. And things like consent, the need to address sexual orientation or gender identity, and even the sexual orientation and gender identity are not necessarily covered. However, curriculums are required to cover sexual assault and sexual abuse. What that looks like is debated. So whether that's appropriate, that's really up for debate. And all of sexual health education in Georgia is reported as underfunded significantly. So when you talk to Native Georgians, many have said, I did not even get comprehensive sexual education at very critical times in my reproductive life. And when we talk to adolescents, they're hungry for comprehensive sexual education in Georgia. Next slide. So moving to that, we also see this sort of lack of protection in Georgia. Georgia has 632,200 people who live in low-income contraceptive deserts, and 7% of counties have not a single healthcare center that offers contraceptives. What this really means is that numerous people are going with their needs for contraception unmet. And it's particularly problematic in more rural areas or farther away from places like Atlanta or larger cities. This means that like 44,950 women are, and this study only really covered women as the gender, so I'm sorry, are living in places without even a single healthcare center that can offer them some contraception. Next slide, sorry. Georgia does have public funding for family planning, and public funding for family planning is extremely key. And I think we were all kind of very concerned about what public funding for all kinds of healthcare will look like in the future. We have right from the start Medicaid, which is focused on pregnant women. And when I say family planning, I mean more than just contraceptive use or birth control provision. Okay, so family planning includes things like labor and delivery care. It includes checkups. It includes a lot of other things in that umbrella. But we have right from the start Medicaid, which is focused on pregnant women. And this covers from the start of pregnancy up to 6 months after birth. And that was a hard-fought win. It's a recent change for low-income people in Georgia. And eligibility is up to 220% of the federal poverty level. And children can also be covered under right from start Medicaid up to 19 years old. There's also P4HB, or Planning for Healthy Babies, and women can receive services, or people can receive services up to 24 months. And then finally, Title 10 is critically important in Georgia. Title 10 is the federal funds that usually cover family planning services in Georgia. It means that usually there's no charge for clients up to 100% of the federal poverty level, and offers sliding scale for contraceptives. In Georgia, Title 10 covers the most amount of contraceptive provision. Next slide. So It's interesting. So, where does emergency contraception fall? So, thinking about, the changes in our political landscape, emergency contraception is coming to the forefront as a extremely important. And there's only been a few studies, very relatively small studies in Georgia of emergency contraception provision, but a recent study by a pharmacist at the University of Georgia studied 600 pharmacies and they found only 57% stocked Plan B. And it's much more likely to be available in metro areas than other areas. Again, another rural urban health disparity in our access disparity in Georgia, right? That I'm pointing out. Plan B is also often at greater cost than generic options. And usually when we're thinking about emergency contraception, it's Plan B that's stocked, not the generic versions. And finally, pharmacists are not as well trained as they should be in understanding what the requirements are for Plan B. That actually there's no age requirements, parental consent requirements, or any other kind of requirements. It's an over-the-counter contraceptive. It's also not an abortifacient, meaning that it cannot cause an abortion. And there's a very specific efficacy window within 72 hours of taking the pills, but oftentimes pharmacists in this study couldn't describe what the efficacy was appropriately. So there's a lack of education even on the need for immediate contraceptive use, right? Next slide. And finally, we can come to the point where I think almost everybody on this panel probably knows Georgia is considered highly restrictive of abortion. HB 481 or House Bill 481 is what we kind of live under, but HB 481 went into effect after the fall of Roe in 2022, the summer of 2022, but it was administered or it was started earlier than that, right? And that law essentially says that abortion is illegal after embryonic heartbeat is detected. And that's as early as 4 weeks after last menstrual period, or you will often hear in the ethos that's approximately 6 weeks of pregnancy. Okay. But it's important to know that it's the detection of the heartbeat, which is not medically accurate, that actually defines whether or not somebody can get their abortion. Patients also have to kind of navigate a whole host of other laws that were in existence before. So although we've restricted by time in pregnancy, there's also other things that restrict providers from providing and also coverage, cost coverage. So state Medicaid does not cover abortion care in Georgia, except in extremely limited circumstances, but it's very unlikely that people are getting acceptances for those limited circumstances. So on average, researchers say that state Medicaid doesn't cover abortion. And then we also have a parental notification law. So if a minor tries to get an abortion in Georgia, their parents must be notified. Also, we have a physician only rule. So physicians can be the ones who can do procedural or medication abortion, which is the pill-based abortion. And then we also have a 24-hour mandatory waiting period. So once a person seeks an abortion, they still have to wait 24 hours and also be counseled with non-evidence-based materials. So you can see the hurdles that people are facing. Next slide. So to add to this, now where we've talked about contraception, where do we fall in terms of pregnancy? What's happening in Georgia is that the pregnancy landscape is getting more dire. And this is from both, a workforce perspective. There are less and less OBGYNs in Georgia that are able to practice, but also Georgia is home to what we call maternity care deserts. And March of Dimes has a bunch of great information on maternity care deserts if you're interested in learning more. But basically, since 1994, 41 labor and delivery units have closed, usually due to lack of profitability. Labor and delivery units are not very profitable business models, but that has made the trek to looking for birth care for people in Georgia um, uh, long. On average, it's increased the average Georgian person's travel time about 13.5 miles. But for people in rural areas, you see even more of a disparity. It's increased at about 3 times. So people in rural areas are traveling up to 63 miles to look for birth care. And again, the caveat, you see women throughout, but it's because many of these studies have been done with people assigned female at birth, mostly identified as women. Keep going. Oh, sorry, next slide. Yes, thank you. And then finally, just to cap it off, we have to think about systemic racism that goes on in Georgia. And this is a really difficult topic to talk about, but you know that during COVID, violence against AAPI spiked during the COVID-19 pandemic, and particularly in Atlanta. I want to honor the fact that in 2021 there was the Atlanta spa shootings that you know, really targeted members of our community. And NAPAV was at the forefront of organizing many, many protests against what was going on. And Stop Asian Hate has a lot of really good data on where we are at with AANHPI racism and violence. And why I bring that up is because this is also embedded in our healthcare system. And it's been shown that that AANHPIs are studied less in terms of discrimination and racial experiences that they might have, but they experience them just like any other group. And so I'm going to stop there and just kind of conclude and say, you know, the landscape for Georgia is complicated, but we have a lot of really important groups on the ground working to examine these health disparities, and then also to figure out ways from a social, political, and an overall structural lens to tackle them. And I'll stop right there and I'll just give it over to you, Fedra.
Thank you, Dr. Narasimhan. And again, our sincere appreciation to RISE for supporting this critical research and their commitment to person-centered access to reproductive healthcare in the Southeast. Dr. Narasimhan will join us later for Q&A. So if you have thoughts, responses, please feel free to drop those again in the Q&A box and hold on to those for later. So next slide, please. I'm going to go ahead and present some of the key findings from our research report. And just a heads up, this will not be comprehensive. It's quite a lengthy report and there's a lot in there. So I encourage you all to check out the report itself. Given that we have limited time, I'll just offer some key highlights. Next slide, please. So Dr. Narasimhan provided such a beautiful overview about the partnership between NAPAV and RISE and how the report came to be. So just a little bit more about our methodology. Despite being the fastest growing racial group in Georgia, and unsurprisingly, we know this, AANHPIs are largely invisible in reproductive health research. When the data does exist, it's often aggregated under a broad racial category, and that obscures critical disparities between subgroups. So to bridge this gap, NAPAV partnered with RISE, and we did a comprehensive mixed methods study. We focused on 4 metro Atlanta areas where 62% of AANHPI populations reside. Our study surveyed almost 500 AANHPI women and gender expansive folks, and then supplemented that with 6 focus groups to capture deeper qualitative insights. That approach allowed us to uncover individual, community, and policy level barriers that shape sexual and reproductive healthcare access for communities in Georgia. And, you know, I've gotten the question before, why both the quantitative and the qualitative piece? And just a quick note on that for folks on the call who maybe aren't as familiar with research. So, you know, our communities encompass a variety of ethnicities, languages, and cultural practices, and that diversity means that a singular data collection method might not capture the full spectrum of experiences. So with the quantitative data, you know, surveys, they provide measurable data points, and that offers a broad overview of trends and commonalities. And, you know, one example is like our survey revealed that 83% of respondents had a regular reproductive healthcare provider. At face value, this suggests satisfactory access. When we look at the qualitative data, though, it complicates that understanding. So the focus group discussions unearthed deeper issues where participants shared experiences of discrimination and cultural insensitivity and challenges with finding providers who understood their specific needs. And it's these narratives that highlighted that just having access to a provider doesn't actually equate to quality or culturally sensitive care. So by integrating both data types, we get a comprehensive understanding of the obstacles that our communities face. And then it's this holistic approach that then makes sure that our policy recommendations and interventions are grounded in both statistical evidence and personal experiences, which leads to hopefully more effective and empathetic solutions and interventions. Next slide, please. So while our report focuses on Georgia, the barriers we uncovered reflect national trends impacting AANHPI reproductive healthcare access. Language barriers are a persistent issue with over 100 languages spoken among our communities, yet very few sexual and reproductive health resources are available in multiple languages. Another major issue is culturally incompetent or insensitive care. Many healthcare providers don't understand community cultural norms around, for example, modesty, family involvement, or stigma. And then that often leads to miscommunication, patient discomfort, and even just complete avoidance of care. And then within AANHPI families, sexual and reproductive health conversations remain rare. Only 11% of survey respondents said that they turned to family for information. And this demonstrates low intergenerational knowledge sharing, which can leave especially young people particularly vulnerable to misinformation. And then finally, economic and policy barriers exacerbate sexual and reproductive health issues or access issues. In Georgia, Medicaid and accessibility to some folks in our community, restrictive abortion laws, and the lack of community-centered clinics disproportionately impact our communities. And then addressing these issues requires policy shifts and targeted interventions, which we'll discuss later on in the presentation. Next slide, please. So now I'm actually going to present some of the key findings. Next slide. Thank you. So first, I want to talk about provider access and bias. One of the most striking findings from our report is the extent of provider bias faced by AA and HPI communities. 63% of respondents reported experiencing discrimination or unfair treatment in sexual and reproductive health settings. That includes hospitals, clinics. This number is even higher for Asian respondents at 70%, while mixed race and Native Hawaiian Pacific Islander respondents reported slightly lower rates of bias at 24% and 22% respectively. What does this bias look like? Many respondents shared experiences of being dismissed when discussing sexual and reproductive health concerns. So one respondent described how her provider implied that her UTI was caused by infidelity rather than listening to her symptoms. True story. Another spoke about how her doctor assumed she needed birth control simply because she was unmarried. These types of interactions break trust and discourage people from seeking care. Our findings also highlight that provider identity matters. Participants emphasize the importance of having a provider of the same gender. It was around 42%. They emphasized non-judgmental attitudes and racial or ethnic similarities when selecting a provider. The healthcare system has to recognize and respond to these preferences to improve trust and quality of care for AA and HPI communities. Next slide, please. Cultural stigma around sexual and reproductive healthcare is a significant barrier for our communities. So interestingly, 64% of foreign-born respondents felt that there was less sexual and reproductive health stigma in the United States compared to their countries of origin. However, that doesn't mean that stigma isn't a major issue within AA and HPI families and communities. Our study, as I alluded to earlier, found that only 11% of respondents turned to family for sexual and reproductive health information. Many shared that conversations about contraception, about abortion, or even basic reproductive health were considered taboo. One participant described how her mother discouraged her from getting a pap smear because it was uncomfortable. Another said that her family believed discussing sexual health could encourage premarital sex. This silence has consequences. Participants reported avoiding care or feeling ashamed when seeking contraception or abortion services due to fears of being judged. We'll discuss interventions later, but quickly want to note that to address this, we need community-driven efforts to normalize sexual and reproductive health conversations, to provide education in culturally relevant ways, and to ensure that healthcare providers understand the impact of stigma on their patients. Next slide, please. One of the most important takeaways from our report is the severe lack of sexual and reproductive health knowledge among our communities, especially around abortion. So nearly half of Native Hawaiian Pacific Islander respondents, that's 48%, and over 40% of mixed race and Asian respondents said they felt little to no knowledge, had little to no knowledge about abortion care. So then we asked the question, well, where are AANHPI individuals getting their information? Our study found that 43% turned to community-based resources, around 41% relied on healthcare providers, and only a small percentage, again, had family discussions. A lack of comprehensive, culturally relevant sex ed in schools only worsens these gaps, and Dr. Narasimhan was talking about that earlier. Participants in focus groups talked about Googling their sexual and reproductive health questions, seeking information on social media, or relying on misinformation spread in community circles. This lack of knowledge leads to confusion about reproductive rights, especially in restrictive states like Georgia. And to improve access, we really need to work to ensure that communities have accurate, accessible, and culturally competent sexual and reproductive health education. Next slide, please. So next I want to talk about judgment and pressure when it comes to contraception. AANHPI individuals often face unique pressures when it comes to contraception. Our study found that 37% of Asian respondents felt pressured to use birth control, but the pressure wasn't coming from doctors, which was surprising to me. It was coming from family members, partners, and cultural expectations. This aligned with another key finding that only 4% of respondents reported feeling judged by healthcare providers when seeking contraception. Instead, many felt scrutinized by their families or communities. Some Native Hawaiian Pacific Islander and mixed race participants reported feeling judged for not wanting to use contraception altogether. So it's judgment just on the other end. One participant described how her parents insisted she take birth control despite not being sexually active, just to, quote, protect the family's reputation. Another spoke about hiding her birth control use from family members to avoid gossip. These findings underscore the importance of culturally competent and sensitive reproductive counseling and community-driven conversations that support personal autonomy without external pressure. Next slide, please. So next, I'm going to be taking up some potential policy recommendations to consider both at the state level and the federal level. Next slide, please. To truly address the disparities, and there are so many, in reproductive healthcare access for our communities, we have to implement bold state-level policy solutions. First, we need to expand Medicaid to include all immigrants regardless of status. Right now, too many immigrants, including long-term residents, are left without healthcare coverage because of restrictive eligibility rules. Georgia Medicaid covers qualified non-citizens, including lawful permanent residents or green card holders, but there's still a waiting period, or there may be a waiting period of 5 years after receiving qualified immigration status. And it also doesn't cover immigrants who don't have legal status. So second, cultural sensitivity and humility training has to be required for healthcare providers. Our research found that AANHPI patients often, again, experience racial bias, dismissive treatments, and a lack of understanding about their reproductive health concerns. Training providers to recognize their own biases and communicate effectively with diverse communities can only build trust and improve health outcomes. Third, we have to invest in community health centers in AA and HPI neighborhoods. So really going and meeting people where they're at instead of expecting them to come to traditional quote unquote health centers and sexual and reproductive health contexts. Many community members prefer to receive care from providers who speak their language and understand their cultural background. Yet again, community health centers serving AA and HPI communities are often underfunded or inaccessible. Increasing funding would allow these centers to provide essential reproductive health care, including providing contraception and prenatal care. And then finally, we need to improve data collection on AA and HPI health outcomes. Too often, AA and HPI health disparities are hidden again because data is either not collected at all or it's lumped together in broad racial categories. Disaggregated data would help policymakers, advocates, and healthcare providers better understand the unique needs of different subgroups and then craft policies and interventions that truly address those needs. Next slide, please. Thank you. And then the federal landscape is a tricky one, especially right now, but we do believe that there is good change that can take place if we mobilize community. And if you have questions about that, happy to take it up during the Q&A portion. But we need strong federal action, basically to protect and expand reproductive healthcare access. First, I want to talk about a little bit about the HEAL Act, which if you want more information about that, happy to cover that in Q&A, but also feel free to go to our website. Right now, again, I alluded to this in the state portion, many immigrants have to wait 5 years before they can access Medicaid and Medicare, and that leaves them without basic health care during some of the most vulnerable years of their lives. Among other things, the HEAL Act would eliminate this waiting period and allow all immigrants to access the care they need when they need it. So I encourage you all to read more about that. It will be introduced later this year, and we will be mobilizing folks for that. So you can also subscribe to our website to learn more, but I'll talk about that a little bit later as well. Second, we must fully enforce Section 1557 of the Affordable Care Act. This section protects patients from discrimination in healthcare settings, including discrimination based on race, gender, language, and immigration status. However, enforcement has always been inconsistent. And many patients who belong to our communities continue to experience, obviously, discrimination. Strong enforcement would ensure that healthcare providers uphold those protections and provide equitable care to everyone. Third, as Dr. Narasimhan talked about, sex ed is incredibly important. Our research found that AA and HPI young people are often left out of sex ed curricula, leading to widespread misinformation and confusion about reproductive health. Comprehensive, culturally sensitive sex ed available in multiple languages would empower AA and HPI young people to make informed decisions about their health. HRSA programs are also important. They should be expanded to support community-based reproductive healthcare initiatives. So HRSA is the Health Resources and Services Administration. It funds clinics that provide care to low-income and immigrant communities. Additional funding would allow these clinics to offer language-accessible, culturally relevant reproductive health care to patients. And then finally, we have to protect abortion access at the federal level. Georgia and many other states have passed restrictive abortion laws that disproportionately impact people of color, including folks who belong to our communities. And we know this, abortion is healthcare, and restricting access forces people to travel out of state, delay care, or carry pregnancies against their will. And this comes at the expense of lives. Congress has to act to protect reproductive freedom for everyone, regardless of where they live. And NAPOF is also working on a campaign to protect abortion access. If you want to check it out, it's called the Abortion Access Now campaign. Can talk more about that during the Q&A portion as well. Just want to put out there, these policy changes aren't just ideas, they're necessary actions to ensure that our communities can access the reproductive healthcare they deserve. Next slide, please. This is my last slide before we open it up for some Q&A. So exhale. I just want to be explicit and direct in saying that we're living through incredibly difficult times. The national landscape is radically shifting, and in Georgia, we're seeing firsthand the consequences of policies that strip away reproductive freedom and dignity. It's really easy to feel like we're up against forces that are too big to fight. But what I want us to remember is that we're not powerless. Our knowledge is power. The findings in this report give us the tools to challenge misinformation, to push for better policies, and to demand that healthcare that our communities get is the healthcare that they deserve, which is quality healthcare. When we name the barriers, we're one step closer to dismantling them. I also just want to remind us all, myself included, that our stories are powerful. Lawmakers may ignore data, but they can't ignore the voices of real people. So every time we share our experiences, whether it's about navigating a complex healthcare system or facing stigma or being denied care, we build momentum for change. And most importantly, our communities are power. The same resilience that's carried us through generations of exclusion and erasure are going to carry us forward now. We've been here before, fighting for our dignity, for our rights, for our futures, and every time we've found ways to push forward. So yes, these are challenging times, but hope is not passive. It is a call to action, and we take action by organizing, by advocating, by voting, by ensuring that no one in our community feels alone in this fight. So not to get on my soapbox on this, but we do have knowledge, we do have stories, and together we really do have the power to make change in the course of reproductive justice for our communities. Thank you for being part of this work just by attending, and let's keep going forward. It's the end of the slides. So we're going to open it up for Q&A right now. So I see, hi, Dr. Darrisman. We got one question in the chat. Thank you for the webinar. Thank you for attending. Is there data on the demographics of the providers as well? And if that impacts what patients experience at all? Fantastic question. So for this research, we didn't specifically ask, but in the focus groups, people did note that they had providers that were not of the same cultural identity. Oftentimes they were white providers, and that really impacted the kind of experience that they had. But I think regardless also of the demographics themselves, the providers just had no awareness of the kind of cultural expectations and realities that people are holding. So part of it, I think, is training, and then part of it is also just, yeah, a misalignment in terms of identity matches. And as the research illustrated, that is a critical factor for folks when they're deciding which provider they go to. So another question is, why do Asian respondents report higher rates of negative experiences with providers compared to other folks in the study? So that several factors may contribute to this discrepancy. Healthcare providers can harbor unconscious biases. They can view patients through a lens of stereotypes, such as being quote unquote compliant or stoic, and then that leads to dismissing patient concerns. And then I don't want to generalize. We know that our communities are not a monolith, but there are certain cultural norms that often emphasize deference to authority and non-confrontation. And I just want to put out there, there's a huge power differential between a provider and a patient to begin with, right? And even when you're an advocate, it can be incredibly challenging to move through that power differential and to push back as needed. But patients from our communities may hesitate to ask questions or express dissatisfaction, and then that leads providers to interpret their silence as agreement or understanding, which is a misinterpretation. And then just to also uplift from the previous question, the underrepresentation of Asian healthcare providers can result in a lack of cultural understanding and relatability, and then that makes patients feel alienated and misunderstood. Another question, and Dr. Narasimhan, I'm wondering if you have thoughts on this one. Is there any data on women that are part of the intellectual developmental disability community?
I do think that there is some small level data on folks who are part of the intellectual developmental disability community. I think there's a lot more research that needs to be done in that group and in that community that's less that's not focused only on I would say like ha harms and kind of like I wonder if the reproductive justice lens needs to extend to examining research in that community. So what I can do actually is after this, I can find some resources because that's not exactly my area of expertise, but I'm happy to find some studies or resources that have been done in that area.
There was also, I believe, a brief that got put out, I want to say by CAP, the Center for American Progress, that talked about disability justice. That might be interesting to look up, and I can quickly look it up right now and put it in the chat. But so there are, I think, resources out there, but definitely the connection between reproductive justice and disability justice can be made even stronger in some of the research, both methodology and analysis.
So I think one question, Fetcher, is do you have data on medical professionals refusing reproductive filling services or filling prescriptions based on moral or religious grounds? Is that present in the data?
So that wasn't present in the data for this report. But I through my previous work, I have heard of medical professionals, doctors, nurses refusing to provide care because of their beliefs and very much against their code of ethics. And I think a lot of that comes down to state policies, individual state policies. It's a pretty fragmented policy landscape right now. So it really depends on what state you're in and how much discretion providers have and their ability to do that.
And Georgia does have does allow providers that conscientious objector status. So they can refuse to provide certain types of care. You see that in abortion care, particularly if they feel that it goes against their religious or moral background. However, I think that's a really important question. Uh, and I think it kind of dovetails into the next question, Fezzer, which is about feelings of pressure and judgment and whether or not over-the-counter options like EC and O-pill might decrease those experiences of judgment and pressure, and also how privacy factors into those experiences. Do you guys have any data on that from the report? And I can comment on it generally.
Yeah, so I wish I could see that. I want to make sure I'm capturing the question. So I think my impulse is to say more access is better, right? Oh, there we go. More access is better. I think and more access where people are at is better. So again, I think making sure that if folks want contraception, they can get it in their local pharmacies, in their local community clinics, that can only improve health outcomes. That said, as our research showed, just having a sexual and reproductive health provider doesn't actually mean you're getting access to care. And even when you are getting access to care, that doesn't mean it's quality access to care, right? So making sure that if we're providing contraception or whatever, any kind of medical intervention in a different setting, that we're also making sure that there are materials that are language accessible and that we have folks who also understand, can answer questions that come up in that context. And I'm also wondering, I'm also thinking about settings where there are pharmacy deserts, right? We talked about abortion care deserts. There are also pharmacy deserts. So really I think about care more expansively in that way and making sure we're taking into account just the lived realities of folks who belong to our communities. And then I think the question had, privacy considerations. Yes. Yeah, I mean, that's a big question right now for all different kinds of sexual and reproductive healthcare. The research that we did for this study, I think, complements the research that we did for a medication abortion study that we put out, I think, in 2023, that showed us that folks want to get care the way that is most easy, the way that's easiest for them. And if they know that it's available, they will access it. So a lot of folks in our community, for example, didn't know about the abortion pill, right? But once they understood what the abortion pill was, then they wanted to get access to that pill as opposed to other modes of or other methods of getting abortion. So I think there's a fair bit of education that needs to take place, but and that goes to sex ed and resources again that are language accessible and culturally relevant. But once we have that, I think people do tend to err towards options that are more private that allow them to, access in the ways that make sense for their lives without needing to take time off of work or have, someone come with them or talk to someone about it, that sort of thing.
Yeah, I think the data is pretty clear that if you remove barriers like needing parental consent or going to a pharmacy rather than having to go to a doctor's office, getting things over the counter, all of that data was used in order to make emergency contraception and O-pill over the counter. O-pill, is widely available. I think like in Georgia, in metro areas, O-pill is widely available, even though you still, in some places like Walmart and Target, you still have to um, ask a member of the service team to open the lockbox for you. So that can pose a bit of a barrier. But I think we are really wondering what the O-pill distribution will look like outside of the metro areas and thinking about if there is one pharmacist in your town or one pharmacy, what that looks like for a young person who might be of AANHPI status going to that one pharmacy. The privacy piece there, it can be really difficult. I think there are other modalities of getting things like the pill and contraception, especially telehealth and telemedicine. And I think that kind of information really needs to be distributed widely to young people with AANHPI backgrounds, because those are ways that you can access that kind of care without necessarily having to go to the same physical space that other people might know you, and it's safe and reliable. Um, and, privacy and always, matters. Security always matters in sexual and reproductive health. And so, and uh, the idea of around pressure and judgment is all ever present. And young people of all backgrounds, but probably specifically this group, do feel different kinds of pressure both to use and not use contraceptives. So our hope is that like more research focuses on, person-centered contraceptive counseling, person-centered autonomy, right? So how can we make sure we meet the person where they're at without prescribing what they may not want?
Thank you for lifting that, Dr. Nurseman. And I would also just highlight, what our study showed is that the judgment in terms of contraception wasn't coming from providers, right? It was coming from family and friends and cultural groups, like cultural community. And so part of me is also thinking, over the counter options make it more accessible, but it doesn't quite get at that piece, right? So thinking about like how do we disrupt that in a way that makes sense and is like, culturally appropriate, culturally sensitive? How do we make some of these conversations less taboo and combat the immense misinformation that's spreading around contraception specifically on those platforms that young people and a lot of folks in our communities are getting their information solely from, so social media primarily. I'm recognizing that we are at 3 p.m. So I just want to thank everyone, 3 p.m. Eastern, I should say. I just want to thank you all for joining us today to stay up to date on these and future events, as well as, many of the other issues that are coming up. Please sign up for our email list. You can visit NAPAWF, NAPAWF.org to subscribe to our newsletter. On March 27th at 12 p.m. Eastern, we're going to be hosting a virtual event on the work of the Chicago Reproductive Justice Coalition. We're releasing a report shortly that's going to explore the experiences of women of color, including barriers to healthcare, specifically in Chicago. So registration details will be available soon. So keep an eye out for that. And then I just, again, want to thank Dr. Narasimhan again for her time and her incredible insights and joining us for today's conversation. Thank you all so much for coming, and hopefully see you at another future webinar.